Welcome to It's a Grand Life. Did you know that in the United States alone, 2.4 million kids are being raised by their grandparents or other family members other than mom or dad? 2.4 million. It's a Grand Life is a podcast for those grandparents and kinship caregivers who are committed to making a difference for those kids. Grand families are in every neighborhood, every city, tribe, and territory nationwide. If this is you or someone you love, this podcast is for you. Our goal is to offer hope and resources to help you. Please subscribe to our YouTube channel or follow us wherever you get your audio podcasts and leave a review. Every new subscriber and review helps us reach others that need assistance. Welcome to another episode of It's a Grand Life. Hello, my name is Craig Nash. We'd like to welcome you to another It's a Grand Life. And we've had many of our listeners or podcast viewers request information on how do we deal with addictive behavior in our kids, in our grandkids, and how does that affect the little ones that we're trying to raise and to help them in this grand life. And you're just going to love our guest today. We have Maddison Cross on with us, and she is with a group called CNS Healthcare, and they absolutely and unequivocally specialize in dealing with especially this dual diagnosis disorder. I'm going to let Maddison get into it with us and really explain all that goes on in this process. And Maddison, I know you guys are so busy over at CNS Healthcare. We're delighted that you're here with us, and I know we had to move some things for you and I to get together here today, but what you're dealing with is such a hot topic for our grandparents who are raising their grandkids. First of all, thanks for joining us, and then can you explain what you do at CMS Healthcare?
Yeah, absolutely. Well, I appreciate you having me. One of the biggest things is having these conversations and really spreading the word. We see that a lot with mental health and substance use, ending the stigma. So that's a great place to start. So I'm glad we're having this conversation. But my specific role at CNS Healthcare is I'm a supervisor of an assertive community treatment team. So we are going out into the community, we're going into homes, we're essentially meeting individuals where they're at. So whether it's at the library or the gas station, we really want to be able to meet kids and adults where they're at in the community. We want to break down those barriers, transportation or other things that they might be experiencing that's kind of hindering them from receiving services. So we're out in the community, and my team specifically is an integrated dual diagnosis team, which you had mentioned. And what that means essentially is that we're dealing with co-occurring disorders. So a lot of times in kids, you'll see substance use more as a secondary issue. So a lot of times they might be struggling with mental health. This is in children and adults. And then substance use is also something that comes into the picture, and they're kind of, dealing with both at the same time. So that's something that we see a lot in the community, and that can be difficult to navigate because you have two pressing issues that you're trying to sort through and figure out. So that's my role here, is to help those individuals kind of navigate those two different areas that correlate together.
What was very interesting to me, Maddison, what you just kind of hit on, is that when most folks think of behavioral health, they're thinking of the patient going to see the healthcare professional in some sort of setting. Yes. You folks are going in the field, you're meeting the patient where they are, and that's a whole new dynamic. And I think I salute you for doing that, because sometimes it's very challenging to consistently get in front of your patients. I know that I used to own a complex care management company where we would work with total healthcare patients, for example, that had 2 or 3 comorbidities that were in and out of the hospital. And if we could connect with them in their home and build a relationship and address any of the social determinants that may be driving these readmissions, we could really keep the patient healthier and reduce the cost of healthcare significantly. And is that what you're seeing as well by going directly to the patient's environment?
Yeah, absolutely. And, I think the biggest thing that, we see with being able to do that is when we're trying to address all the systems in an individual's life. And, if they were to just come to an office setting, we might not be getting the full picture. So we might not be able to see kind of what's going on in the home or what their home environment looks like, or do they have a safe place to sleep? Is there food? All of those things that might affect a child or an adult in their home environment, we have a better idea of how to assist somebody when we can see all those different factors in their life and meet them where they're at in the community.
And the other thing that's interesting about you, what the work that you do is you really supervise a team. It's not just one individual or one specialty going out to see a patient. What type of specialties or subspecialties would make up your homebound team?
Yeah. So my team specifically, we have 3 case managers. So those are all clinicians. So if somebody was wanting to have those therapy sessions, those one-on-one sessions, we're trained in those. And then we also have a peer support specialist, and we have those all throughout CNS healthcare, not just on my team, but that is a crucial component of CNS healthcare, is having those peer supports, because what that means is they have also experienced a mental health issue or a substance use issue in their life. And so they're bringing that personal experience to the individuals that we serve. And that can kind of take away that power dynamic of, I'm talking to you or at you, as opposed to, no, they've been with them in that experience. They've also experienced that. So that really helps us connect to our individuals. And then I also have a nurse on my team as well. And so she is addressing the physical, components of somebody's life, making sure they're following up with their primary care. If it's a child, making sure they're getting those annual physicals. And we'll go as far as to driving the child to that appointment, or the adult to that appointment, and scheduling and, helping them get a calendar, stay organized. We're trying to bridge those gaps so that those resources become more available.
So continuity of care is a big deal, right? So you want to make sure that whether they're seeing your case manager or your peer-to-peer support or what have you, or your RN, that there is consistent visits, that we're making progress in the care. And we don't care if we go to see them or they come to see us, but you want to really know what's going on in that patient's environment. And sometimes that's a handful. Right, you're absolutely right. And when the patient comes to your pristine clinical environment, it's totally different than you going to their house. And now, does your RN help with medication management at all with the patients? And
absolutely, and that's something CNS does as a whole. We are all pitching in with the medication management side. So the RN plays a huge role in that. We also have, active psychiatrists and nurse practitioners and physician's assistants that are working here as well, that are, helping us navigate the medication side of things. But you'll see clinicians all the time going to people's home, watching them take their medication to make sure that they get that dose. Especially if they're using substances, they might forget or are having a hard time keeping track of that. And so we have the staff and the support to be able to assist them with that and making sure that they're getting the correct medication. If they had an injection scheduled in the office, or we could go to their house and give it there. So again, really breaking down those barriers to making sure that they get that medication that they might need.
And are you seeing an increase in this whole dual diagnosis arena? Are you seeing where, and is one of the diagnoses bipolar, for example, in this type of situation? Mm-hmm. Is that one that you would have, as well as the all of the other issues with the other things you're wrestling with, and the drug use and what have you? And do you have challenges with medications with this population?
Yeah, I mean, we definitely face some challenges. Like I said, when you give somebody their medication, essentially they would be, expected to take it. And sometimes individuals lose track of that, and they also have a lot going on. And so that can be difficult for them to remember to take their meds. But we try to intervene in a lot of different ways. So those follow-up appointments, you know, again, monitoring those medications and making sure we're out there and watching them take them and that sort of thing. So that can be helpful for
So
individuals.
important, right? I mean,
Yes.
they've, and you ever find that with some of your dual diagnosis patients that they're adverse to medication? You might have the greatest medication this side of the Mississippi, but they don't want any of it. And
Yeah.
and you and your team, you're just trying to get some normalization with the patient's care and get some standardization with them, and they're just kind of pushing back on that. What do you do with patients like that?
I think consistency is the biggest thing. So all the time, when individuals even come to my team or refer to a different program in CNS, you might face that hesitancy at first. They might be afraid or ashamed, and we see a lot of that. But if we're consistent and we continue to show up and we continue to let them know, hey, this is a safe space. We're going to help you take care of these things in private. What happens here stays here. And once you provide that consistency, that starts to develop that trust between the two individuals. And especially when you have a team, then you might see individuals developing trust with a whole team. And that's what creates the change when they feel that they can trust the people that they're working with and that that's a safe place. So it might take 3 months to 6 months. I've even had it almost a year where we keep showing up and we're
Wow.
like, this person really just might not be budging or they're hesitant. And then, a year and 1 day later, they say, I think I'm going to try to go on that medication, or I'm really thinking I need to move out of this home environment and try that safer house that you were talking about, or, maybe I'll go to that domestic violence shelter that you've been mentioning. And so
Excellent.
really just providing that safe space, because a lot of individuals don't have that and they're not used to that type of support. So that's the support we're trying to provide.
And I would imagine with that peer-to-peer element to your team support, that folks can't pull the wool over the eyes of over the peer-to-peer folks. They've been there, they've seen it all, they've done it. They're not just clinical, and that's got to really help improve the effectiveness of your team, I would imagine.
Absolutely. Absolutely. I mean, me personally, I'm coming from more of a clinician standpoint. And, there are individuals where they're trying to have a conversation more about what's that feeling like when you are in the cycle of addiction and you can't get out? What's that like? And, we can relate and use our educational pieces as much as possible, but having that peer support really shows them that they're not alone and other people have been going through this as well or have in the past. And it also shows them, look where you could be as well in the future. If these are the steps you're willing to take, you could be in a role that is educating folks and helping them through that process as well.
And have a mission and a purpose to help others.
Absolutely.
So when you're dealing with this dual diagnosis population, when you're talking about medication management and different things with them, are you saying things like that? Like, look, if you get on the meds, we can get you stable and you can start to re-enter into society and as a normal transition and get your life back. Is that the main motivation for these dual patients?
Absolutely, absolutely. We're always coming from an education side of things, and we're promoting independence within these individuals.
Right.
So we want them to be able to do it. We're not here to do it for them, but we are here to assist them with
Right.
accomplishing those goals. So, in our treatment plans and all of that, those personal sessions that we're doing, that's the goal, is to how can we help you accomplish these things on your own when you get to that point.
But having the patient stabilized is vital, right? It's
Absolutely. And those are reoccurring conversations. And so yes, when you have a team of people, reminding them that, it's kind of that motivational interviewing piece. So I might say something like, Well, 3 months ago when you were on your Medicaid or medication assisted treatment, you were doing things that you really enjoyed. I saw you go to the park and you even were riding your bike outside and you smiled more as well. Can you tell me about how you felt during that time? Did you feel different than you might feel now? And then they're starting to come up with ways that they felt better during that
Right.
time, and it's re-providing that motivation, and so they can remember where they've been and where they can be in that stable place.
That is just so good. So um, I talk to a lot of grandparents who are raising their grandkids, and our situation for my wife and I, and when our daughter, who's dealing with a dual situation as well, and I've talked to many grandparents whose kids are. They could be patients of yours because, in fact, you could be supervising their care through your department because this is something we see all the time. But if you are at home right now and you have got a child that perhaps is experimenting with drugs
Mm-hmm.
and you start to see things escalate, uh, Madison Cross, when do you know to say, wait a minute, this is going beyond recreational, quote unquote, to where it's substance abuse, and that where it triggers something from the behavioral health side where they need more than just a nice pamphlet, but they need to meet with your team to try and get their life together. When is that switch flipped? Or is it different for every patient?
I think it can be different for every patient, and it can be hard to determine where somebody's at in that process. So my advice, or my team's advice, essentially would be the earlier the better. Let's work in a preventative way. So in a proactive way too. So for example, our children clinicians, if you get in with a children clinician, you're following the same clinician throughout the whole process, and you're able to talk about those things in a safe space. So if somebody is, using drugs and they're a child, and um, it's escalating, let's have them talk to somebody about that. Why are they using? Is it a peer pressure thing? Is it because of things going on in the home? Is it because it's what their friends are doing? There's so many different factors, but providing that safe space and a safe adult is huge. And you want to do that as early as possible, because sometimes we can see that gap between individuals of an older generation and the younger generation not knowing maybe how to talk about those things correctly, or not knowing the right things to say when their grandchildren are struggling with that, or their children, because times are different. But you can kind of bridge the gap when you have a safe space to talk to somebody, because they can help the family work through those things, and be on the same page about what might be happening.
And Madison, and on top of that, what should we be looking for as parents of these grandkids that might point to more drug use than just casual drug use? Or when should we address the potential for addictive behavior?
Yeah, I mean, I think you could see a lot of things start to happen. Maybe isolation, not being happy or finding joy in activities that they might have before. Kind of withdrawing from social activities, so things in school, or not wanting to go to school, or not wanting to participate in extracurricular activities. A change in mood. You can see that a lot with children. So getting angry or lashing out, or having a shorter fuse. Those can all be signs to look for, that lack of motivation.
The lack of motive. These are great things. Isolation. There's no joy in their life. They're withdrawing. They're moody. Wow, that's um, that could happen a lot with adolescents at home, and you toss on that the abandonment issues of the parents are gone, and there's all sorts of unfortunately potential triggers for the need to chat with a professional like yourselves and your colleagues at CNS. But how big a problem is this? The dual diagnosis problem of the drug use as well as the behavioral health issues.
Yeah, you mentioned that earlier, and I've been, kind of thinking about that question. It is increasing, and um, I think the reason why, for the most part, and with children, I think we see this more often. With adults, it might be a little bit harder to identify, but when we're having a mental health issue and struggling with anxiety or depression or bipolar or schizophrenia or whatever it might be, you know, we are left feeling lost at times. And it can be painful and it can be hard and sad to go through that process and very lonesome. And then that's when you start to see the substance use. What can I do to numb these painful feelings? What can I do to numb the fact that I might be different or that I might be experiencing something that I feel other people aren't experiencing. And that's when we see that substance use component come in. And so it's that easy out. But what people don't realize is that it, is the easy out for the moment, but for the longevity, it is not sufficient to curing those issues.
That's absolutely great. And I know we've spent a lot of time on talking about your specialization of the dual diagnoses, but what are some of the other issues that CNS healthcare treats for your patient population?
We have so many programs. We would be on here for a long time if I went through all of them, but I'll start with the children's first. So we have an infant mental health program, wraparound services, intensive home-based services, outpatient, school-based services. So all of those things again are what we discussed: being in the community, being in the home environment, being in the schools, really trying to figure out all those systems in an individual's life and helping them navigate through that. We also have a behavioral health program. So that's really addressing the physical health side of things, getting people linked up with doctors, nurses.
Wow.
Yep. And then we have the ACT program, which is what I'm over for adults. And so that's really an intensive adult program. So making sure that individuals are staying out of the hospital, staying out of jail, and living independently in the community with those supports. So those are just a couple to name off the bat.
But if folks were interested in finding out the whole breadth of your treatments or specialization, they could go to cnshealthcare.org.
Yes.
Right?
Yep, they could absolutely go on there. The website will list those programs. And if somebody really is interested in just even exploring those options, it doesn't even mean that you have to go through the process, but essentially we would have people call the OCHN access line in Oakland County for us. And I'll throw out the number. It's 464-6363. And that access line will set you up with somebody where you can discuss all the things you might be experiencing and going through, and they will put you in the right direction. So whether that be a children's service, whether that be a therapist, whether that be an outpatient service, whichever one it might be, they would be able to discuss those options with you and point you in the right direction.
So if someone is interested in putting their toes in the water, they could call 464-6363 and talk to a healthcare professional about what they're wrestling with and get pointed in the right direction. And I do think you're 100% right. When I looked on your website, which is terrific, you have so many things that you address, which is great. But we do not have the time to go through each one, or Absolutely, you and I'd be here till Christmas. But encourage everyone, at the bottom of your screen, you should see the CNS web address, the CNS Healthcare web address, cnshealthcare.org. And Maddison Cross, we just salute you for the work that you're doing in helping our folks stay out of the hospital and get some normalcy in their life as they deal with behavioral health and also substance abuse issues. And we just salute the work you guys are doing. And I hope you'll come back on again with any new programs you want to kick off and discuss, and just continue to help our audience know what is current in the area of behavioral health and substance abuse treatment. So thanks so much for being our guest here on It's a Grand Life.
Absolutely. Thank you for having me. I appreciate it.
Thank you for joining us today for It's a Grand Life. It's a Grand Life provides vital content, regulatory updates, and subject matter experts that are committed to supporting the 2.4 million kids and their caregivers from every neighborhood, every city, every tribe and territory nationwide. Please subscribe to our YouTube channel or wherever you get your podcasts and leave a review. Every new subscriber and review helps us reach others that need assistance. As caregivers, we are united in purpose. We are driven by hope while providing strength for today and hope for tomorrow. We are truly making a difference while living the grand life. If you have a suggestion for a future episode, please reach out to us. But we'll see you next time for another It's a Grand Life. Thank you for joining us.